So, hello everybody. Welcome back to the Stoke Mandeville Plastic Surgery Educational Series. And as always, we are grateful for the support of the Plastic Surgery Trainees Association in the UK and also the International Confederation of Plastic Surgery Societies, ICOPLAST. So today I'm thrilled to introduce my dear friend, Dr. Honda Su, who is an assistant professor and a plastic surgeon at the Darlin Shuzi Hospital in Taiwan, and he's a huge rugby fan. So Honda, you and I met in Taiwan about 1.5 years ago when I was there for my fellowship. And it was Roel, our mutual friend and scrub nurse at Oxford, who suggested I looked you up on Facebook because you'd met him as a fellow, I think, in Oxford about 12 years ago. So
yeah, you told me you need someone to babysit you.
Yeah, well, when I got to Taiwan, I gave you a shout, and literally within a few days, you came by and picked me and one of my friends that a resident you'd never met and took us out for sushi and sake with your wife. And you also made me learn how to make sushi from the chef and embarrass myself in front of the restaurant. So thanks. Well, you're one of the most generous and funny guys I've come across, and brilliant surgeon. You've given me lots of really good advice since I started as a consultant. So thanks for that. So how's the family and the whole COVID situation in Taiwan? How's it all going?
No, we're actually doing quite well here. There's no lockdown, and we are free to move around. So don't be jealous. We can go to restaurants, we can go to pubs. There's no ban on liquor and there's no ban on cigarettes. So we're allowed to go outside, go get some drinks. So we're quite lucky to be in Taiwan during this period of time. So at present in Taiwan, it's been about 30 odd days now where there's been no confirmed local cases. So slowly we are opening up. So when you come to the hospitals now, you can just enter now. Whereas before you had to say where you've been, your travel history and things like that. And nowadays, you can just walk in. So, the practice is picking up speed again.
Great. And just so our audience knows how lucky we are to have you actually join us today. Late last night, you sent me a text saying that you might be a bit too knackered to do this because you just done 23 hours of straight operating on, you did three flaps on your own because your resident's on holiday, and then you were...
Well, there was two routine reconstruction for the head and neck. And then late in the early morning, the ICU told me the one flap I did last Thursday didn't look so good. So I had to go back in and salvage and did another free flap. So three flaps in a day. Yeah. Look at the top, but I've got coffee to keep me going at the moment.
That's great. And then you did a full day of clinic before this webinar.
Yeah, I had a full day of outpatients today.
And finally,
call me Iron Man.
Iron Man, yeah. So your surgical career is fascinating. You grew up in South Africa. You went to medical school in Cape Town, is that right? And you traveled a bit?
I grew up I was born in Taiwan, and then I grew up in South Africa. And then I did my training in Cape Town. I've got some slides later on to show everyone, just to see who this dude is and why he speaks with such a funny accent. I don't speak with a Taiwanese accent, and I don't speak with American accent. And it's not quite British, so it's a South African accent for all of you who's wondering why I speak so funny.
The international citizen. So, well,
yeah. I speak English, and if there's anyone here that speaks Afrikaans, I speak Afrikaans. And then I speak a spattering of Xhosa, which is a local dialect in South Africa. And then I speak Mandarin, if somebody needs to hear it in Mandarin, and I speak Taiwanese.
Let's stay with English for them.
Yeah, for sure.
So Honda, we've been looking forward to hearing your talk. Diabetic foot reconstruction is going to become a big part of plastic surgery, I'm sure, going forward, because diabetes is now so prevalent, it's only getting more common. I do owe you an apology. When I invited you to come and chat to us, I said there'll be 30 people, but it seems now 151 signed up. Anyway, that's as always, I'm sure there'll be lots of comments and questions. So if everybody can jot them down by clicking on the Q&A function at the bottom of your screens as we go along, and we'll get to them at the end. So thanks very much, Honda. The floor is yours.
Okay, I'm going to try and share the screen. Let me see if it will work. Oh. Okay. Right.
Perfect.
Okay, so it's, can you see the screen all right? Okay, so today, since there's only 30 people talking, so I'm gonna think there's 30 people listening to me, and it'll make me less nervous. James asked me to speak about reconstructing the diabetic foot while using a free flip. Apparently, he tells me some people are not sure that this is the thing to do. It seems to be quite a routine thing here in Taiwan for us to do a salvage of the diabetic foot. So like James just said, with the pandemic going on at the moment, in Taiwan, we're really relatively quite safe. We can go out, not like you guys, where you're in lockdown, where you can only, decide whether you want to go to the bedroom or the living room or the bathroom. We can go outside to the restaurants, so don't be too jealous. For those of you who are not quite sure who this bald Chinese Taiwanese guy is, I actually work here in a tiny island just off the coast of China in a place called Taiwan. And I work in a place, Jai County, which is basically to the south of Taiwan. For those of you who don't know where it is, it's basically at the foot of Alishan Mountains. And like I said, why do I speak with such a funny accent? Well, I grew up in a place called South Africa. I actually went there when I was about 8 years old. And I did my junior school, high school, and I did my medical school there. And after medical school, I did 3 years as a general practitioner in South Africa before the crime got to me. And so I decided to leave and came back to Taiwan. So I trained in a beautiful, beautiful place called Cape Town. And this is the Groote Hospital. And this was the camp where, so you can see it was actually a beautiful place. And it's actually quite sad to leave South Africa. At the moment, I work for quite a well-known humanities society called Tzu. And they have members all over the world. And that was one of the main reasons why I came back to Taiwan. And like James said, I was in Oxford I think about 10 years ago, just over 10 years ago. And I met Roll, which is this funny looking, which is this funny looking guy here. And he was the one that told me there's a guy that's coming to Taiwan from Oxford, and he's called James. And apparently, he's got a naughty boy, and he needed someone to babysit him. So I can see in the picture, like James said, he actually didn't come here to learn about microsurgery. He actually came here to learn how to do sushi, and I hope we taught him well. All right, so I think back down to the main topic today of my talk today, which is about diabetic foot reconstruction. Apparently, according to James, in the Western countries, some people think that because in a few years' time you're going to amputate these legs, some people feel it's not worth it to go to all this effort to save these legs. But here in Taiwan, and I think in a lot of the Asian countries, the people are born with the idea, culturally, the saying is that whatever your parents gave to you at birth, you need to take it with them when you meet your ancestors. So in other words, when you die, you need to take your whole body to meet your ancestors. So at times in Taiwan, and I'm sure many of the Eastern Asian countries, it's very difficult to amputate a part of the body of a patient. So even if you want to amputate a toe or amputate a leg, it's actually very difficult. Some of these patients, they actually will go home and die rather than have you amputate their legs. So like, in this picture, I don't think there's a right or a wrong choice, but it's a decision that you need to take. So I'm going to give you a couple of cases just to demonstrate and to see what people think. The first case is a 52-year-old diabetic male patient, and he comes in with this picture. And this is, when they come to the emergency rooms, and this is what we very often see this here in Taiwan. They come in with a rotten leg, wet gangrene, they are feverish, they are septic, the sugar is high, the renal functions are not good. So what do? You know, they come in like this. This is the plantar view. So you can see the toes, the second and third toes are involved. It's gone into the plantar foot. It's gone into the deep plantar space, and it's going into the medial side of the foot. This guy's really sick. So what would you do? Would you amputate this leg immediately, or would you try and save it? The things you got to think about is this it's actually quite a young guy. He's only 50, he's only in his 50s. So you're going to have to think about what you want to do. Often when you see a problem like this, it's like a mountain to climb. You know, this guy's septic. You're going to try and save his leg. Are you able to do it? You know, so often maybe many of us will take the easier path. You go straight, and the road is nice and wide. All right, and you finally arrive at your destination, maybe faster. But if you take, you know, the less taken path, it's smaller road. It's more winding. It takes longer to get to your final destination, but you will get there. All right. So this is basically the same thing as when you're trying to do a diabetic foot salvage. You know, and this is a saying that I often I like very much. Nothing is impossible. Just when things look impossible, there is a way. There is always a way. So this is not from Winston Churchill Einstein. I don't know if you guys watch a lot of TV like me, but this is actually from, sorry, I think I've just lagged. This is actually from Grey's Anatomy. You're going to be a bit of in the 40s or 50s like me to have watched Grey's Anatomy. Right. So when you're faced with a mountain of decisions like this, a difficult decision like this, you know, keep calm. You know, a lot of people say it's your life, your choice, but in this case, it's the patient's life, it's the patient's leg, but it's your choice as a doctor whether you decide to keep this leg or not. So it's actually quite a difficult decision to make. When I started out as a registrar or as a resident, the picture on this side is what we often see. This patient comes in, they get amputated below the knee. A couple of years later, they come back and they get the other leg amputated. So at the moment, what we try and do is we try and save these patients' legs, right? So that they can walk or at least keep their body image as intact as possible. So for that case, what I did was I did a debridement under local anesthetic, because these patients often have peripheral neuropathy. They are numb. You don't need a general anesthesia. You don't need a spinal anesthesia. This guy is septic. If you place him under general or a spinal anesthesia, you might kill him because of the high anesthetic risk. So a simple local anesthetic, do a fasciotomy, debride it quickly, get the pus out, and put these patients into the ICU, stabilize them. Place them on broad spectrum antibiotics according to your local hospital's guidance, and then dress the wound. Okay, in this patient, the distal pulses was not palpable, and the ABI and PBR that was done showed a peripheral vascular disease. So we consulted the cardiovascular surgeon, and they came in. And what we normally do is when they arrange a time to do an angioplasty, we at the same time will do further debridement with them at the same anesthetic episode. So when this patient is stable, he went back in, had an angio done, and an angioplasty at the same time. So this is the result of this angio. So you can see multiple stenotic lesions. And as you come down to the knee area, where you're supposed to see a trifurcation, almost absent flow. All right, and anterior tibial artery, you can see multiple stenosis and almost absent flow. Going further down into the middle part of the leg, you know, this is not adequate vasculature. All right, so as you go down into the foot, all right, you can slowly see some flow in the posterior tibial, and you can see some flow in the anterior tibial and dorsalis pedis, but this is just all from a collateral flow. Okay, so what we asked them to do is they did a angioplasty for us. All right, so you need to have cardiovascular surgeons or vascular surgeons or radiologists that are very keen to do this type of procedure. They are actually very important. If they can do an adequate revascularization, it makes our lives as a reconstructive surgeon much more easier. So you can see in this patient, after a good endovascular angioplasty, a good flow is seen into the anterior tibial, the posterior tibial, and the dorsalis pedis. So this makes your life much easier when you want to do a microvascular reconstruction. So we're going to do a free flap to the foot. So further debridement was done. As you can see, almost the whole of the plantar foot, the deep plantar space was gone. So the 2 toes were sacrificed. This is what I often explain to my patients. If you want to save your foot, sometimes you need to sacrifice these 2 toes. If you don't sacrifice them and you try to keep them, soon these other toes will get involved and you will not be able to save them at all. Once the wound is nice and clean, at this stage, you're going to think about reconstruction. All right, so for this foot, I don't think a skin graft will be adequate. It's very difficult to perform a local flap in this area. So I did a free flap. So once it's clean, I did a free rectus femoris muscle flap, and I covered it with a skin graft. I often do a lot of muscle flaps because I work in a hospital where we are a single, well, we operate as a single surgeon. So from the first incision to the last suture, I do everything myself. All right, so to harvest a muscle flap, it's very quick. It takes me about 30 minutes to harvest either the rectus femoris or the vastus lateralis, and they have got a nice long pedicle to use. All right, so that's why I often do a muscle flap. This is after 2 weeks. So you can see the flap has taken well, and it's contoured well, and the skin graft has taken well. And then at a long-term follow-up about a year, you can see the contouring is good. The muscle flap often takes about within a period of 6 months, the muscle flap should atrophy to about 2/3 of its original size. And sometimes it doesn't. At that time, you might consider debulking procedure if the patient wants it. Often they are happy if they are able to walk around or they've saved the leg. They're happy not to undergo any more further procedures. So you can see that this leg, this guy has been walking. You can see callus formation. So it doesn't mean that you've done a muscle flap with a skin graft, that these people can't walk. These skin grafts actually hold up quite well to be placed in the foot. So another case is similar. You're gonna meet up with more and more of these patients. 70-year-old diabetic, they are under hemodialysis, and they come in same with a rotten leg. The toes were amputated, all right, and so you can see there's a big defect. So as our level of medical care gets better and better, our patients are living longer and longer, and so we're going to see a lot of these old diabetic patients. All right, it's the same thing. You know, they come in, the vessels are poor. You can't palpate the distal pulses. So the first thing you need to do when these patients come in is you need to palpate the distal pulses. If you cannot palpate the distal pulses, you need to check the ABR and PVR. If the ABR and PVR is poor, you need to get your cardiovascular or your vascular surgeons involved. So it's basically a lot of teamwork. You need to have someone, you know, the vascular surgeon must be motivated to do this. And so you can see the distal part of the anterior tibia, you can't see it. And the whole thing is, I don't know if it's clear on everyone's skin, but the whole vessel is calcified. And this is what we often see, that we see a lot of calcified vessels. All right. And the posterior tibial, it's also at the distal part, it's also, I'm sorry, the dorsalis pedis, it's also, you know, you can hardly see it. But after a good revascularization, the flow comes back well. Then you can choose which vessel you want to anastomose to. Often I can ask the cardiovascular surgeon to say, is it possible to revascularize a specific vessel for me? Because the defect might be closer to that, to that vessel. And it's easier for me to do anastomosis to that, because then you don't need to have such a long pedicle. All right, so you can see after revascularization, there's a good flow. So in this case, I also did I think this was a vastus lateralis covered by with a skin graft. All right, and the long-term follow-up, you can see this patient is walking. You can see that in this picture, the toes are already a bit black, and they're walking around all right. You can see the dorsal view is still slightly bulky, but this patient is fine. He was, sorry, he could wear his shoes fine. He could wear his slippers fine. So he could walk around all right. So it was not much of a problem. All right, so these two cases might seem a little bit difficult for those who are actually just starting out on their journey of trying to do free flap reconstruction of the diabetic foot. All right, we are not all of us are super microsurgeons like JP Hong and the Masters series. So this is not so much a Masters series talk, but a lot of us are just basic. We just normal plastic surgeons. We do our normal plastic surgery, and then we have a special interest in microsurgery. So in some cases, it's not so complicated, like in this case. This guy came in with a wet gangrene of the big toe, and it's a young man. So we amputated the foot, the big toe, but you can see there was exposure of the first metatarsal head. And so in this case, we did a small muscle flap, covered this with a skin graft. Sorry about the poor focus. And there was good take and with good contouring. So long-term follow-up, you can see that this guy is also walking around. Okay, so these are much easier cases. These are small defects with good vessels. These patients are some of these patients that not everyone will need revascularization. Okay, so these are the simpler cases. Okay, so not all flaps need to be a muscle flap. This was a patient who had a diabetic patient who injured his Achilles tendon, and the orthopedics had tried to fix it, but was complicated with an infection. So we debrided this wound, we placed him on negative pressure therapy, and then once the wound was clean, we did an ALT flap, okay, and we used the fascia part of the ALT to reconstruct the tendon. So skin fascia cutaneous flaps also work very well. It just depends on what you're comfortable with. A lot of the trend I see in the International Microsurgery Club are people talking about perforator flaps. Okay, so once you're more comfortable anastomosing to the big vessels, I think at that time is when you can move on to doing a perforator flap, because these vessels are much smaller and much more difficult. You can see that this toe was infected. After debriding it, the defect was not big. So you need basically a very small flap. Sure, you can argue that you can do a skin graft, you can do secondary intention, wait for the wound to heal, right? But you can also do a small perforator flap like this. This is the proximal lateral leg perforator flap. You can see the flap is small and it's thin, but basically it's more difficult because the pedicle is shorter and the diameter of the pedicles are quite small. This will be in the 1 mm region. But it gives you good contouring. You don't need a skin graft, and this is a one-stage thing. So it gives a good contour, cosmetically acceptable flap, and these patients can wear their shoes with no problem. Okay, now the question comes, is it worthwhile going through all this hard work when these legs will get amputated at a later stage? And this was actually the question that James put to me. You know, you go through all this hard work, but a couple of years later, you're going to chop off their legs either as a below knee or above knee amputation. Well, I think that's basically a misconception, because when I was going through my studies, I found out in 1986 in Journal of Vascular Surgery, Kigi and their group talked about that primary amputation is a safe and appropriate solution, but in elderly people with critical limb ischemia, there's a high mortality rate, which is equal or comparable to the infrainguinal bypass. So maybe it's not so safe after all. Pomposelli in Journal of Vascular Surgery in 1998 also described that limb preservation is beneficial in terms of overall survival. Okay, so now that we know that it's beneficial, what is its long-term like? Dr. Moran in 2002 published in PRS, he talked about free flaps in patients with peripheral vascular surgery. And in their conclusion, they talked about that free flaps can be performed safely in patients with peripheral vascular disease. The flap failure rates were low, the morbidity was low, the long-term survival in these patients was excellent. Okay, and this is actually what we found with our patients, that once you keep their legs, they're happy with you, they come back and see you, they introduce their friends and their families to you, and they actually stay with you for a long time. Okay, so now that we know that it's worth doing all this, what is the long-term follow-up like of these patients? Okay. This was a paper by Erkey in Annals of Surgery in 2006. And this was actually the paper that inspired me to do all of my research, because I looked at this paper and he talked about salvaging the leg in a critically ischemic, salvaging the limb in a critically ischemic leg with major tissue loss by the vascular and plastic surgery, a surgery with a long-term outcome. But in this article, at that time, they were talking only about open bypass surgery, all right? And their 1 and 5 year amputation-free survival was actually quite good, all right? The 1 year was 70% and the 5 year amputation-free survival was 41%. But you can see the survival rates at 5 years, 63% are still alive, all right? The 1 year is 91% and 63% at 5 years. The limb salvage rate was 73% at 1 year and 66% at 5 years. It's not fantastic, but it's not as poor as what people would like to think. All right, but the thing is, things move forward, and a lot of people, well, a lot of hospitals, they now do endovascular surgery instead of open bypass surgery. So even in my hospital, I can count on one hand how many open bypass surgeries we've done in the past 10 years. Everything is endovascular first now. So everything there will go and do angioplasty. There are more stents, there are more catheters, there are more sheaths for these people to use now. But so my concern was, what is the long-term result of using this combination of treatment, of using endovascular revascularization and a free flap reconstruction in the diabetic leg? So nobody has really talked about it. And so we looked at our patients in the past about 8 years, and just to see what its safety and efficacy of this combination is like, and what it's like in the long-term follow-up. All right, and this was actually published just last year in the European Journal of Vascular Endovascular Surgery. So our topic was basically diabetic limb salvage with angioplasty and a free flap transfer and their long-term follow-up. So now in our study, we found that we had 55 patients over a period of 8 years, and there were 60 legs. Male-female ratio around 30:20, and the average age was about 66.5. So neither young or too old, but you can see the range was up to 89 years old. So some of these patients are actually quite old. The defect was located all over the leg, but most common, they will often involve the forefoot and mixed areas. In other words, it either extends from the forefoot to the dorsal foot to the plantar foot, so the defects was quite large. As you can see, like I said, we are single surgeon operators, so we do a lot of muscle flaps, and we do some of the ALT flaps. When we choose to do ALT flap is when we can see that the perforator is more a subcutaneous perforator. It's much easier to harvest than a muscular cutaneous perforator. So we save time by not doing intramuscular dissection of the perforator. So what I believe is that these people are quite sick. So if you can do your surgery quickly and you decrease these patients' anesthetic time, their post-operative care is much easier. So for a VL or a rectus flap, we can sort of harvest in about 20 to 30 minutes. So we can do a free flap reconstruction of the diabetic foot in about 2 to 3 hours. So we can drastically reduce the anesthetic time, which makes the care of these patients much easier afterwards. The recipient arteries, there are no surprises because these are the only arteries that are in the foot. But look at the recipient veins. We do about half almost, about 30 odd anastomosis to comitant veins. And because they did not do open bypass, the greater saphenous vein is intact. And often we transpose the greater saphenous vein into our defect, into our recipient areas of the pedicles, and we anastomize our pedicle onto the greater saphenous vein as an end-to-end anastomosis. And a lot of the times it works well because it's much easier to anastomose. For the surgical complications, you can see the total flap failure was not high. Out of these 60 cases, it was only 3, but we had a lot of wound infection and hematoma rates. And I think this was basically because in the beginning of the study, after angioplasty, these patients are placed on triple compound therapy for antiplatelet regimens. So these patients are placed on aspirin, they are placed on Plavix, and they're placed on Platel. This is according to our cardiovascular surgeons, their suggestions. So when we did the free flap reconstruction, these patients tend to ooze quite a bit. And so we developed a lot of hematoma and wound infections. After 2-3 years, we found that this was one of the reasons. So prior to do the free flap reconstruction, I think my dog is complaining, I'm talking too long. We stopped these antiplatelet therapy 2 to 3 days before surgery. And after that, we found our hematoma and our wound infection rates decreased radically. The medical complications, there was nothing out of the ordinary. Right, so the limb salvage rate was actually quite good. We had a limb salvage rate of 98% in the first year and 88% in 5 years. The patient survival rate was almost very similar to Urqui's group. In other words, 93% is still alive at 1 year and about 67% at 5 years. The amputation-free survival was also pretty good. At 1 year, there was 94%, and at 5 years, there was 68%. So if you look at the new and the old group, in other words, the old group was where they did our open bypass and a free flap, and the new one is where we did angioplasty and free flap. The survival rates are very similar. The leg salvage rates are slightly better with the endovascular group, and the amputation-free rate was also slightly better. I don't think it's because this is a better method. I think it's just because the care of these patients, and we have more ammunition to use in these patients than before. Basically, this is about a 20 years difference between the studies. Right. But basically, what are the major advantages of doing this? I think the major advantages with the endovascular angioplasty is that you don't need a general anesthesia. All right. So you can do these patients under spinal anesthesia, under IVG, intravenous general anesthesia, or you can do it under local anesthesia. For these patients, there are less surgical wounds. They don't have to end up in a high care or in an ICU. And so because there's no bypass surgery, there's less morbidity. And because it can be performed under local anesthesia or under less invasive anesthesia, it allows us to be available to a broader spectrum of patients. So in this group of patients, we waited for a week interval between angioplasty and a free flap reconstruction. This was basically, we want to make sure that the angioplasty vessel had remained patent and there were no acute thrombosis or intimal dissection, and that the wound has become cleaner after debridement before we do the free flap. Right, so after this talk, it's basically not that difficult. I hope that the younger, the registrars or the residents, after hearing this, you can do this. It's not actually that difficult. If you've got a good recipient vein, artery and vein, you can do it. Okay, so what are my tips for doing a reconstruction after diabetic foot? Right, number one, to me, is the most important, is always do an end-to-side anastomosis. In other words, you've got to do an end-to-side to your major vessels. So if you can anastomose to the dorsales pedis, the anterior tibial, or the posterior tibial, always do an end-to-side anastomosis. Don't sacrifice your main vessels. Save the collaterals. All right. So when we do a reconstruction in the head and neck, we often clip, and all the collaterals we clip because it's such a good blood supply in the head and neck, and then we leave the main trunk. But with a diabetic foot, these patients are different. They often have peripheral vascular problems. So you need to save the collaterals. So don't clip these collaterals. You can sort of temporarily ligate these collaterals. Once you've done your anastomosis, you release the collaterals. You want to save as much feeding vessels to your leg as possible. Use the greater saphenous as a recipient vein. To me, it's very nice. It's very easy and very simple to anastomose to the greater saphenous vein. All right, and these greater saphenous veins are actually much bigger than the Comington veins, and they also provide a good caliber. Right. If you read in the books, if you join Facebook and you're on International Microsurgery Club, you often find people talking about super microsurgery. You find people talking about thin flaps. You find people talking about perforated flaps, and you find people talking about the very popular flaps at the moment, the skip flap and the medial sural. All right. But for me, yes, I might be able to do it. It takes a little bit longer, but I like to do the flap that I'm comfortable with. So I have a lot of experience with using a rectus femoris or the vastus lateralis or the anterior lateral thigh flap or the proximal lateral leg flap. These are the flaps that I'm very comfortable with. And so these would be my first choices. And I think that's the same to everyone who's starting out on this journey of reconstruction. Do a flap that you are comfortable with. You don't have to follow what everyone else is doing, because this patient, you are in charge of your patient. You got to know what you can do and what's best for the patient. So I always choose the flap that I'm most comfortable with. Right. So if the other thing is, often these people have atherosclerosis, and when you dissect out the recipient artery, some parts of the artery might be calcified. So what I do is I go and I use the microforceps, and then I sort of squeeze the artery, and I find the part that is soft. And often you can see with the naked eye which part has got a calcified plaque and which part doesn't have a calcified plaque. Then I would anastomose onto the place where there's no calcification. This makes the end-to-start anastomosis much, much more easier. Sometimes the whole artery is got an atherosclerotic plaque. Sometimes even your flap artery pedicle has got an atherosclerotic plaque. So this makes for anastomosis much, much more difficult. In these cases, you're going to have to think about doing an end arterectomy. But the thing is, if you do an end arterectomy, you should be, it's much more difficult, and you're worried about plaques falling off. Okay, so you should be prepared mentally that you might have to go back and to do a flap salvage. This is quite common. All right. So if you do see the whole thing that's calcified, it's actually quite more difficult. Sometimes the whole thing is so hard, the whole artery is so calcified, it's so hard that you can't even penetrate it with your 909 rod. And in these cases, you sometimes have to just give up the free flap, close the wound, and then just go back for a conservative dressing. So my pearl is, you need to know your limits. All right, we are all human. We are not God. We are not all masters, like a lot of the masters that are speaking on the Masters series on the webinars. But you need to know what you can do and what you can't do. All right, so you need to know your limits. What can you do? All right, and remember Murphy's law. Anything that can go wrong will go wrong. And I think that was last line like me. After 2 free flaps, I was quite tired, and I thought, oh, go back and have a beer and get some rest. And then I had to go in and salvage a flap that was done 4 or 5 days ago. So anything, be prepared for things that can go wrong. All right. So what do you do when things do go wrong? Have a plan B, right? So what's plan B? Are you going to do another free flap? But are you brave enough? Because it's actually quite mentally quite a burden when your free flap fails. All right. You feel the stress. You stress yourself, and it's a stress on how you can explain it to your patient, and it's a stress on how you can explain it to the family. So are you brave enough to do another free flap? Well, for me, if the vasculature is good, in other words, the recipient vessels are good, then I might. But if the recipient vessels are not that great, in other words, they are heavily calcified, then I would not be brave enough to do another free flap. At this time, I'd look at about doing a local flap or propeller flap. But like in the first few cases, it's very difficult to do a local flap or propeller flap to the bottom of the sole of the foot, and especially when the defect is so big. So what can you do? Well, remove the flap, because like I said, these patients have undergone revascularization. So in other words, there's better blood supply to these areas. So if you do conservative dressing, give it time. Sometimes you just need to buy time, all right? With time, the granulation slowly appears, and you don't actually have to amputate these legs. When there's adequate granulation, often after a few months, at that time you can do secondary, you can wait for secondary intention to happen, or you can do a skin graft. At this time, you can think about hyperbaric oxygen or topical oxygen. I think this is a good time for these accessory methods. All right. But remember, everybody will feel depressed, because when a flap fails, you will feel depressed. You spend so much energy and your time into doing it, and then you see a black flap in front of you. But just remember, you've tried your best and you've done everything in the best interests of your patients. You didn't start out to harm your patients. You started out to save their legs. And these patients and their family, they know this. And deep in their hearts, they do really appreciate what you do for them. And I think this is part of us being a plastic surgeon. We're very different to the general surgeons, we're very different to the cardiovascular surgeons, and we're very different to the neurosurgeons, because we don't, you know, it's not like them. After surgery, our patients either die or live, you know. So when their patients live, these patients are very grateful. But in these patients where we saved their legs, they are actually very, very grateful for you to have tried your best. So what can you do? Try harder the next time. And just because of one failed case, don't give up. You know, nothing is 100%. So even in head and neck surgery where the vessels are good, the success rate is in the 98%. But like I said, 98% is not 100%. So you're gonna get a few cases that are gonna fail, okay? But just don't give up, all right? Remember, someone out there is probably having a worse time than you, all right? So even like me, after qualifying as a consultant for over 10 years, I still have to go in and salvage my flaps. So it happens. Just don't get despondent. Don't give up. All right. So far in this talk, I've been going about how to save these legs. But you also need to know when you should walk away and give up. All right. So when do you walk away and try and do not save these legs? Okay, when these patients come in with a life-threatening illness, they are in septic shock, you need to give inotropes to save them. All right, so in these cases, you need to amputate this severely infected leg to save their lives. Remember, if the patient has poor general condition, this is what I always say to my patients. It's better to be alive with an amputated leg than to die with a leg. So there's no point to try and save the leg, and then afterward this patient dies. So you need to assess your patients properly. So if this patient has got a poor comorbidities, in other words, they are in heart failure, their blood pressure is not great, the diabetes poorly controlled. So you need to assess your patient as a whole. Does he have enough oomph for you to go and save their leg? In other words, these patients might not have enough reserve, and halfway through saving this leg, this patient will die. So this is actually a bit more difficult, but you need to assess your patient as a whole. Right. The third thing is you need patient's consent and cooperation. In other words, you need a motivated patient. If a patient is severely depressed, he doesn't want you to save their leg, then it's pointless for you to go through all this hard work of trying to save their legs and they don't cooperate. In other words, you tell them to stay in bed. After your free flap, they come down and they walk on the flap, you know, and then it causes bleeding and all the problems. But if they're not motivated, I wouldn't do it. And the family needs to be motivated, because in Taiwan, the family plays a part a big part in the care of the patients. So if the family doesn't want these legs to be saved, I always think twice, all right? The third thing is when there's nothing left to salvage, sometimes they come in like this, you know, and it's so severely gangrenous that what can you do? If you're trying to do revascularize in these cases, you might cause a reperfusion injury and these patients can die. So when they come in so in such a bad condition, this is the time when I would suggest amputation. All right. But sometimes, like in this case, you try your hardest. You remove the places that don't look good. You ask the cardiovascular surgeons to revascularize these legs. But even after revascularization, repeated debridement, this wound goes south. It doesn't want to heal. You can see this. You can, you know, this is our mark for a handheld Doppler. They can heal the Doppler, but the gangrene just doesn't want to give up. The foot just gets more and more gangrene. Wherever you debride or you amputate up to, it gets gangrenous up to that area. So sometimes the major vessels might be patent, but the small flow vessels might not be. And in these cases, it's better off with an amputation. And just because these patients undergo amputation, it's not the end of the world for them. As in this case, this is a 50-year-old patient, okay? And he comes back in and he's had a right knee amputation. But you can see, look at his face, he's happy. He's happy, he's walking around with crutches. If you look carefully, he's got his car keys. He's still able to drive. So it's not the end of the world for these patients. Once you've tried and it's failed and you've had to amputate the legs. This is a more elderly woman. She's in her 80s. She was 81. And also she came with such severe infection that we couldn't salvage the leg. And so she also underwent a right below knee amputation. And you can see, this was close on not even 6 months. She can get a prosthetic leg. And this is just an ordinary prosthetic leg. This is not one of those very high-tech prosthetic legs. But she's in the 80s and she could walk with the help of a walker. So it's not the end of the world when you have to amputate these legs. Right. So just remember, the success rate of limb salvage in these patients is not as bad as what one would think. But you need to remember, the fate of these patients are in your hands. You need to place yourself, if it was you, would you want your leg to be amputated? All right. So I don't have stocks in Nike, but if you are keen on doing reconstruction of these legs and you are happy with doing a free lap, I think you should just do it. The more you do, the more experience you get, the more you can do for your patients and the more legs you would save. And I think just to end off this is basically my treatment algorithm. Once you've decided to keep the legs, okay, so what I do is I divide the wound into either infected or a non-infected wound. If it's an infected wound, these patients are septic, debride the wound first. Don't worry about the vasculature. Once you've got the infection almost under control, you need to look at their ABI and PVR. And from this, you need to decide whether they need to angioplasty, they need to do a stenting. And once this is successful, you can think about reconstruction. All right. So I hope everybody has learned something from this talk. I haven't made it very theoretical. I just talked about my experiences. So I think we are open for questions. I hope everyone's still awake.
Yeah, well, we've still got 155 people, so you are still awake. So thank you very much. That was an absolutely wonderful talk. It was really clear, really informative, and really succinct and entertaining. So thanks for that. There are lots of questions, but I wanted to start off asking one for myself. So your paper and everything you've talked about is very much geared towards looking at the amputation-free survival of these limbs. But of course, what a lot of people are interested in is the functional outcomes. Do you have a feel for what percentage of your patients will have a functional outcome, and what you think the predictive factors are, for example, the pattern of foot loss?
Right. James, I think you've asked a very good question. The thing is, in the Far East countries, I really didn't look at function. And I actually described this in my paper, because here I like the term limb preservation better than limb salvage. Because like I said, culturally, it's very difficult to amputate these legs. These patients might have had cardiovascular problems, they might have had a stroke, they might be bedridden. But the moment you talk about chopping off the legs, no, I don't want my legs to be chopped off. Push him. No. All right. So in Taiwan, we always talk about preservation. Whether they can walk is not the main aim here in Taiwan. But if they were able to walk previously and you've successfully reconstructed the legs, there's no reason why they can't walk after you reconstructed them. All right. So once you've saved the legs, they basically go back to what they were like before they got a wound in the foot.
Okay, great. Thank you. And the other question, which ties into a question that Rebecca Shirley, who you've met, and she's a dear friend and colleague of mine, we're partners in crime.
All right, I see the question.
Yeah,
I'm actually learning how to do this now.
Yeah, so it was really about the kind of preoperative vascular studies that you do. When would you consider doing this imaging? And you talked about, whether you can palpate the vessels. Can you talk a bit more about that?
Right. Okay. So Rebecca asked this is actually one of the, should be in my tips. All right. So the vascular surgeon might have revascularized the leg. Sorry. Don't worry about the cough, guys. Have I lost just about 50 people now because of the cough? All right. So Rebecca, it's a very good question. Because it's teamwork, but both the vascular surgeon have to explain to the patients and their family, and we have to explain to the patient and the family. And they often say, oh, we've done a good job. It's well vascularized. But to do a reconstruction, I would like to palpate the vessels. Okay, so once I've explored it and I palpate the vessels, well, actually, before I open it, I palpate the vessels. If I cannot palpate that vessel, even though they've done an angioplasty, then you've got to be very wary that this is not a good flow vessel, okay? But if there's nothing else you can do, you still need to do a free, I would open it up and then I would explore that vessel. What I like to see is with my naked eyes, I like to see the vessel palpate, all right? So if you open up the wound and you look at the artery, it does not palpate nicely, then think twice before you do a free flap. All right? But if you cannot palpate it, but to the naked eye, it's pulsing nicely, then you can think about a free flap. All right. The third thing is, before you do the anastomosis onto the artery, I make a slit in the artery. All right, and I let go of my clamps, and I like to see a good flow from that artery. So the flow, my teachers used to tell me the flow should hit the end of the bed. In other words, it should try and hit you in the face of the flow. So if the flow is good, then it should be a no-brainer to do a free flap. But if the flow is like a BPH flow, then think twice about doing a free flap, because it means the flow rate is not great. It's not going to supply all of your flap, and so you're gonna hit problems.
So just to piggyback on that, Honda, when you mentioned the complications, you didn't talk about the return to theatre rate. Any rough idea how many patients you need to bring back to salvage? I mean, you have
I think
long-term outcome.
Right. Out of the 60 cases, I looked at most of the ones that went back to theatre was actually those patients that were under dialysis. And out of those 60 legs, we had about 5 or 6 of those dialysis patients that had to go back. I think we're different because all of our cases are done by consultants. We don't have registrars. I'm not saying the registrars are uncapable. all of us have been consultants here for over 5 years before. And so these cases are done by a bit more mature microsurgeons. So maybe that's why the return to theater rate is low. But like I said, sometimes you need to walk away. If it's heavily calcified, you know that your free flap is not going to survive. Close the wound. Don't do more damage to the patient. So sometimes you just need to know when to walk away. And maybe that's the reason why the salvage rate is not as high as expected. But you asked a good question, because I initially expected a higher salvage rate when compared to Erke's group, because they salvage, they are anastomosing onto a nice, fresh bypass vessel, and where we are anastomosing onto the natural vessel, which might be more calcified. So I actually expected a higher flap failure rate, a higher limb loss rate, and a higher going back to theater rate. But I didn't see that, you know. So it's a good question.
Thank you. Next question is by David Izade, very good friend. What are your thoughts about intact sensation as an indicator for salvage and prognosis?
Right. Even if they don't have intact sensation, I reconstruct the foot because they want to keep the leg. So just like I said, in all of these patients, they already have peripheral neuropathy. So they come in aseptic. I would do a local anesthetic and just debride them. And sometimes they don't feel much. But like I said, I think it's a cultural thing. Even though there's no intact sensation, I would still reconstruct them. Just because they have peripheral neuropathy, I don't think it's an indication for amputation. Even after you reconstructed it, your flaps are insensate. My flaps are always insensate. I don't know about others because I do a muscle flap or if I do an ALT flap, but I don't do a sensate flap. And like I can see, you know, these patients can walk around fine. So I think to me, sensate flaps aren't a major thing. I think it's just to have a successful reconstruction keeps me and my patients happy.
Great. Question by Mohammed Abdul Razak. Thanks for your talk. Do you do the anastomosis in major vessels or perforators?
Yeah.
Answer that.
This is a thing what I was trying to talk about. Like I said, if you look at the Facebook groups, a lot of the masters are discussing there. So a lot of them, especially JP, talks about anastomosing to perforators. For his paper he published in PRS, he talked about anastomosing to perforator. To me, you need to be a very skilled microsurgeon. For me to do an anastomosis and to start to a big vessel, it's less technically difficult than to do a perforator. But if you're happy to do a perforator to perforator, I don't see why not. Why JP talks about anastomosing to a perforator is that these perforators aren't calcified. And so they should be nice and soft. Whereas if you're doing anastomosis onto the major vessels, they can be calcified and make things makes life difficult. But like I said, but the caliber is bigger in the natural vessels, whereas the perforator is much smaller. It's more technically demanding to me.
Anna, if I may, James,
yeah.
I think there's also a debate about what is a perforator and what is a side branch. Personally, I find diabetic also really amazing. Still, I don't have the sense for it to the extent that you have, but I do try to go to a side branch just when it's just off the posterior tibial usually. What are your thoughts on that? What do you about the difference between an arteriotomy and hooking it up very closely to the source artery, the side branch?
And that is an excellent suggestion. If there is a side branch close to where I'm anastomosing, then I would actually do what you've just suggested. I would trim it very close to the major vessel, so you can actually do almost the end-to-end anastomosis, and this makes life much more easier. The flow is also much better coming through, so it makes life much easier. Even with the end-to-side anastomosis, it's still technically more demanding, especially in the foot, than to do it to a side branch. So it's a very, very good suggestion.
What do you
Thanks.
use to do the arteriotomy then? 15 blade, an 11 blade,
I
or
do
even knife?
With a sharp blade. I think it's 11. It's not not a normal scalpel blade. I think it's 11. I do a puncture with a sharp knife, and then I slit it. And the length is, it depends on how big my pedicle is. But then I punch a little bit out of the major artery. So in other words, there's a hole in the artery. It's not just a slit, so that the flow comes out much better.
Great. We've got time for a few more questions. There's one from Dr. Narayana Murthy. Sorry if I pronounced it wrong, from India. Hi, thank you for your wonderful presentation. In your practice, how does HbA1c values correlate with free flap survival? What do you think is the optimal value to do a free flap?
Right. Thanks, Dr. Nara. Not just HbA1c, you need to keep these blood sugars under control. So in our group, we will get the diabetic doctors, the endocrinologists in to come in and do a proper sugar control. If the sugar is out of control, you're going to have problems, not just with the free flap, but just in the general basic care of these patients. So you need to get their blood sugars under control. You need to get the nutrition under control to have a better free flap survival. But I think I always look at my patient as a whole. You can't just see the foot. You need to see this whole patient, because if you just concentrate on the foot, these patients often develop pulmonary edema. But I often explain to these patients and their families, if the arteries in the legs are so bad, the arteries in the heart are not going to be so good. The arteries to the brain are not going to be good. So just in case, I always do this before I go out on a major reconstruction. I always explain this to the patients and the families. In case these patients develop a sudden AMI while they are admitted in the ward, in case they develop a sudden CVA while they are in the ward, and this happens, you need to give them like a flu shot, a vaccination shot before you do all of this, so that these patients and their family are aware that this can happen. And so if they do develop a sudden AMI in the ward, or if they do suddenly get a CVA, the medical legal problems are less.
That's really good advice. Question from Graham Perks, who said he enjoyed your very common sense approach to this topic. He said, great talk on the patients in Europe are fatter than in Asia. Please discuss.
I don't know if I discuss this, I'll get into trouble. We do get fat patients in Taiwan as well, especially with McDonald's and Kentucky being very popular now, and all the cool drinks very popular. But I tend to agree with Graham that we are a bit thinner, not just than the Europeans, but also compared to the Americans. We are slightly less in size. So I think that's the benefit for the Asian doctors. It makes free flap reconstruction, it makes our lives much easier in a thinner patient. I think you're right, in the obese patients, even if you want to do a fasciocutaneous flap, it's difficult. You need to thin your flaps. You need to, if you want to do a muscle flap, you're going to dig through all this fat just to be able to get to the muscle. I think it does make life much more difficult.
A very good question from Shantan Jing. Thank you for your talk. Do you experience steel phenomenon with your free flaps?
This is the question I always get when I give this talk about revascularization and a free flap. I think you can expect it, but I haven't seen it. Touch wood. A lot of papers from before talked about these. That's why I do a muscle flap, and I didn't say it in my talk. Why I do a muscle flap is previous papers have said that these muscle flaps are better circulation than a fasciocutaneous flap. So when you plug it onto your bypass or onto your angioplasty vessel, it gives them a low resistant bed. So the flow off is much better. So it keeps the patency of the bypass vessel or the angioplasty vessel higher. So it gives you a high patency rate. Because it's also a well-vascularized muscle, it can act as a nutrient flap to your bed. So this is two of the reasons why I choose to do a flap. a muscle flap.
Okay. And a question from by Jason Wong up in Manchester. Great talk, Honda. I'm loving your accent. Can you describe your pre-op workup, if any, with diabetic team or the MDT to optimize your diabetic control before surgery? Also, do you guide your resection with MRI for osteomyelitis, or do you just go by the surgical eye and bleeding? And one last question, what do you do for post-op anticoagulation? So,
Okay, right.
Loaded question.
Okay, Jason from Manchester. For my workup, like I said, if they're septic, I would debride it first. If the blood sugar is high, I give them some insulin just to bring it down quickly, but I need to keep the infection under control. Once the infection is under control, the diabetic team comes in. In other words, the vascular surgeon is involved, the endocrinologist is involved, and the endocrinologists are in charge with getting the sugar under control. The nutritionists have to come in and tell the family, because here in Taiwan, the family cooks for the patient. Not everyone eats hospital food. Some of them get food brought from home. So you need to educate, the dietitian needs to educate them on what they can eat and what they can't eat. So yes, get the infection under control, get the blood sugar under control, and get the nutrition better. Right. After that, I do not do any MRIs or CT scans, all these expensive investigations for my foot. For the osteomyelitis, I just go by my surgical eye. I will debride them until I can feel that the bone is not as soft as in the osteomyelitis areas, and there's actually nice bleeding from the bone. But you can feel it with a rhongia, that when you're crunching the bone, once you get to normal bone, it gets very, very hard to bite through the cortical bone. So I don't do an MRI. For post-op anticoagulation, right. I think there's a major difference between the East and the West. In the East, here we don't see a lot of DVTs. We do see, but not a lot. Okay, so for all of my patients, I give them prostaglandin E1, PGE1. I don't have stocks in them, all right, but it's a routine thing I do. But personally, I think as a microsurgeon, once you've done the anastomosis, you would know if there's going to be a problem or not. All right. So I think for the PGE1, I give the PGE1 to make myself feel better that I've given the patient something. I don't think I actually need PGE1. I think when I'm doing anastomosis, I know whether I'm going to expect problems or not. So here, routinely, we do give PGE1. We do not give aspirin. We do not give low molecular weights, and we do not give any heparin.
Brilliant. I've tried to go, there's so many questions, and I've tried to cover most. Hine, have you got any particular questions?
No.
Yeah. So because oftentimes these ulcers, they use, at least I have some experience. I've done maybe 20 cases. I'm really into it. I think this is where we as plastic surgeons can show benefit in medicine. So oftentimes these patients get visits from home nurses twice a day, which corresponds to 100 euros per day. So just imagine how much money we save our society when we are quicker in providing these solutions. There's two things I struggle with. One is when to pivot, when to go from skin graft to local to free flap. And another thing is at time of debridement, sometimes you put a flap there and the whole surrounding tissue just dies off, and it's like worse than radiated tissue. What are your thoughts on that?
Okay, Anita, for the first part of the question is when do you do a skin graft or when do you do a flap? I like to keep things simple because, like I said in my talk, I work alone. I don't have residents to help me. So I like to,
Me too.
do things quick so I can go home and get a drink. So if there's no bone exposure, there's good granulation, skin graft works well. And I've skin graft a lot of my patients on the plantar foot. I've skin grafted on the heel of the plantar where there's a melanoma. I've skin grafted it because the patient was very old. At the skin grafts, after it's taken and after a while, once it's become like a thickened skin graft, they can you can walk on it. you're not gonna get ulcer problems on the skin graft. Of course, yes, sometimes you do. You'll see a couple that happens. But what I'm saying is that they do tend to last. These skin grafts aren't a problem. The second part of the question is, once you've done the free flap and then the rest undergoes further necrosis, yes, it occurs. But with our protocol at the moment, once we've done the revascularization, I like to see some granulation occur first. I'd like to see that the infection is under control, and that is when I would go in and do a free flap.
Thank you.
Great. Well, I think, you know, we could go on forever, but we've got to come to an end at some point. So Honda, an incredible talk. Thank you so much for your time. I know you're knackered, so I'd give you a round of applause, but we can't do that on webinar.
Thanks, James.
Well done.
Thanks,
well done.
Let's go and get a beer now.
Yeah,
but it's midday for you. We're nighttime here. I can go get a beer. You go back to work.
All right.
Go back to work, guys.